about who we're operating on. That's all confidential. But I can say that this patient is presenting to us, and when I met with the patient yesterday and examined him, he did indeed have pain in his lower back at L34, L45 that seems to be more affecting the left side of the leg. But he had pain in his right thigh. And on better examination, I realized the pain was coming from the hip joint. We ended up doing a diagnostic hip joint injection where we numbed up the hip joint with Novocaine, and it took his pain away. So we confirmed that the right thigh pain was actually coming from the hip joint, not his spine. Very important distinction. So this is just one example of how thorough Deuk Spine is in terms of working patients up to find the true source of their symptoms. Because if you don't find the right source of the patient's symptoms, you're going to end up operating on doing something they don't need done. Sir, it's Dr. Deuk Majan. Are you awake?
Yeah.
Are you ready to get started?
Oh, yeah.
All right. Have you watched these surgeries online?
I watched, yeah.
Okay, good. So I'm going to first give you some numbing medicine, and then we're going to get started. You'll be awake probably for the first 20 minutes, and then we'll put you to sleep, and when you wake up, we'll be done.
Okay.
Sound reasonable?
Yeah.
If you feel discomfort, just say ouch.
Okay.
Can you say ouch?
Ouch.
Good. That tells me to stop what I'm doing and give you some more medicine to numb you up, okay?
Okay.
But don't move your body and try to get off the table.
Okay.
Just remember, moving is not good. I've got a laser in my hand, so you want to just lay still, okay?
Okay.
All right. So I'm going to be talking as I'm doing this. If you have any questions, feel free to ask them as well, but just try to relax. Is there anything you want to do with your position before we get started? You want to move around and get comfortable, or are you good?
I'm good.
All right. We're going to get started, okay?
Okay.
All right. You'll feel a little pinch. That's my hand just kind of pinching your skin, and you might feel just like a little stick and some burning, and that's just the medicine going in, okay? That's just the medicine going in. That's normal. Don't be alarmed. You feel what I'm talking about? Hopefully that's going to be the worst part of the whole surgery for you. Okay? All right. So, this patient has kind of an unusual configuration of the disc at L5-S1. I'm calling it L5-S1. The radiologist calls it S1-S2. But if you look at the iliac crest, the top of the iliac crest run through L4-5, that would make it appropriately called L5-S1. Plus, on the MRI scan that we did yesterday, I could see that the L5-S1 disc, as I call it, is actually degenerated a little bit, which means that there is movement at that disc. So if there's a true disc, it must be called L5-S1. The radiologist that read his study called it S1-S2, which would be inappropriate and incorrect, because an S1-S2 disc would not have movement. All right, we're going to get started. Remember, you let me know if it's hurting you, okay?
Okay.
And I'll give you some more numbing medicine to make you more comfortable. Shot. So I need to see the left side a little bit better. Otherwise, that's a good view of the spine. Shot. Good. All right. So, all right. I'll give you some more numbing medicine to make it feel better. I need you to go to a lateral view. Stay back a little bit, please. Luis, you got to think about, thank you, about me fitting in here. I would just move it there. That's fine right there. All right. Very good. And a shot. Okay, once again. All right, perfect. So we can see the L5-S1. You see that better now? See the pedicle of L5. You can see a small facet joint. Not well developed, but definitely there. Shot. You're happy with the foramen. I'm glad. I'm glad. All right, good. Shot. Are you comfortable, sir?
Yeah.
Shot. Where do you feel that? In your back, right? Shot. In the back, correct?
Yeah.
All right, it must be rotated just the slightest amount. Shot.
Ah!
Where?
In the back.
Shot. AP? Yeah, just relax a little bit. So that's where your bad disc is, okay? That's the first one. And I just want to make sure everything is perfect before I do the next step. So just relax, take a few deep breaths. Should have eased up a little bit, right? All right. So let's go back to a lateral view. I'm happy, but I would like to make it perfect. He's just slightly rotated there, and that may be why it looks that way. Shot. 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 Yeah. You okay? Just in your back, right? AP. So I would say the table could be up slightly more, about half an inch. Up half an inch. Good. Hold on. Shot. So I believe this is the L45. This is the bottom disc. And I think you're rotated a little bit on the fluoro. Let's get that nose between the eyes. Yep, towards you probably, the top towards you. Go ahead. You can do a little better than that. Good. All right. That looks good. So, yeah. All right. You comfortable?
Yeah.
Remember, let me know if there's any discomfort, okay? So we've made our incision, and we're going to place the second cannula. We're going to put you to sleep soon, okay? I just need your help for a few more minutes. Shot. Shot. I think I feel the facet, or that's transverse process. Shot. Let's go to the lateral. Stylet. You're doing good. Everything's fine. Give me that lateral view. Good. Shot. Shot. That's better. Shot. So I'm right at the facet. Shot. Wow. Big herniation. Shot. Yeah. Where do you feel that? Let's go with an AP. So I think he's just a little rotated. That's why we're seeing it. But he also has a pretty good size herniation there. And that's why we're still kind of behind the disc. If you line up the back of the vertebral body, we're about 6 millimeters, 7 millimeters behind, which is just an indication of how large the herniation actually is. Go back to a lateral. And clearly he's feeling it. In your back, but not down your leg. Almost done. Sorry about that. All right, shot. I'm hitting the back of the end plate, the superior end plate. Shot. So I need to redirect north a little bit more. Shot. 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 Where do you feel that? Still?
Yeah.
But not down the leg.
No.
Hang in there. You can't give him a little fentanyl? A tiny? Oh, you did? How much?
100 miles.
Wow. Still uncomfortable? Shot. All right, we're definitely closer, but everything's okay. I'm almost there. I just need another minute or two. Shot. Shot. Same thing in your back?
Yeah.
Just in your back, right? But not down your leg. Shot. All right, I apologize. I hope this doesn't affect our friendship. You're not answering me. Oh boy. All right. What are you doing, Dr. Patel? All right. If you've watched enough of these surgeries, you know what comes next. Do you remember?
Something like
A discogram. That's close, close. Wishful thinking, but we're not quite there. So this is the point where I'm going to do a little bit of investigating to make sure we're in the right spot. Does that refresh your memory? Okay. So you should always use non-penetrating towel clamps for this kind of stuff.
Yes, sir.
Because otherwise you can pinch the skin or you can actually put a hole in the drape. So you want the clamps like that, yeah. Not mosquitoes. It's good to have those on the set. Are you comfortable now?
Yeah.
You're comfortable?
That's the best, no, probably, yeah.
Okay. How bad is that on a scale of 1 to 10?
30.
30. 30 out of 10, L5S1. Is that where you typically get your back pain?
Yeah.
All right, so we found one of your two bad discs. L5S1, 30 over 10. I think everyone could hear that. Sorry, L45. I apologize. You're right. L45. I meant the bottom disc. So L45. L45. Next is going to be 3-4. All right. How bad on a scale of 1 to 10?
40.
40? Okay. Now's where you get to count out loud. Shot. And we're going to put you to sleep. When you wake up, we'll be done with surgery. We found your two bad discs. That's where you typically get your pain, right?
Yes.
Congratulations. When you wake up, that pain will be gone.
No, thanks.
You're welcome. Sweet dreams. Let's count to a 1 from 1 to 100 out loud, please. Starting at 1.
2, 3, 4, 5, 6, 7, 8.
So we call that an evocative discogram, basically testing to make sure those two discs are definitely causing his back pain. Shot, and they definitely are. Why don't you get a quick AP so we have that documented? You can see the dye has run out from the tears in the disc backwards and is running along the epidural space anterior to the thecal sac where the nerve roots are. But both of these discs have grade 4 tears. You're doing great. Keep counting. We're listening. Don't worry. Good. Go back to a lateral, please. Keep counting. You're doing really good. So he's actually falling asleep at this point. He won't remember anything else. And I'm going to place the guide wire through the skin incision. The skin incision is 7 millimeters. The whole surgery will be done through. Can you see this, Zach? Show our audience this 7 millimeter skin incision. There's my finger. It's not even as wide as my finger, okay? 7 millimeters, 2 disc herniations repaired with laser. So we start by placing the dilator over the guide wire, and now this is going to pass through the incision, and it's going to create a path for the tubular retractor where we do the whole surgery. I'm not cutting any muscles, shot. I'm actually just spreading the muscle with that tip of the dilator, and I can actually feel the herniation right now. It's big. It's big. Shot. Yeah, I'm pushing into that herniation as we speak. Okay, and there's a big tear right there. Yep. Shot. And the tip of this has gone through the tear, and I'm going to push it all the way in to the disc space. Shot. All right, so I feel like the dilator has entered the disc. I can remove the guide wire safely, and I can advance this dilator into the disc space. You can see the vertebral bodies distract open. The tear is so big that this thing honestly has gone in quite easily with minimal force. And you can even see it wobbling around. Shot? All right, good. You always want to check the position of your instruments to make sure they don't move. Sometimes they'll move. Now this patient's disc is so badly damaged, I don't think it's going to move. Shot? Now, can the disc heal itself? Yes, it can most of the time, but not his. His discs have been unable to heal themselves. Shot, which is why he's here. He's here for one reason. His disc did not heal itself. So who gets herniated discs? Virtually every human being alive has a herniated disc. Fluoro out. Every single person alive has herniated discs once they hit the age of 35, 40 for sure. But why doesn't everyone have pain? Can I have more volume on the radio? The reason is simple. Most people's herniations heal. It doesn't mean the herniation goes away. It means the symptoms from the herniation go away, and they don't need treatment. But this patient, and many like this patient, actually millions every year, end up with herniations that the pain does not go away, and they need help. And this is the best surgery in the world for a herniated disc, the Deuk laser disc repair. And it's going to be the best surgery in the world for a very long time. Unfortunately, it's only done at Deuk Spine Institute here in Florida at this time in 2019. Most likely it will be done elsewhere in the future, but right now in 2019 it's done here and here alone. So you can see down the tube, I'm going to remove pieces of herniation that I've pushed from the foramen into the intradiscal space. And I'm not able to grab any big chunks, so I'm going to bring the laser in at this point. I need my wristband.
Matt, are we ready with the laser? Good.
So you can see there with the endoscopic view. Guys, we need a laser. He needs you ready with a laser. So in the endoscopic view, you can actually see the blue annular fibers. They're actually white, but they're stained a little bit blue. And some of that is herniated nucleus pulposus stuck down. So I'm going to turn the irrigation back on.
We have a question.
Question. Who says we answer questions? Oh, I'm just kidding. We do.
We
All
have
right, we'll take the question.
We have a viewer asking, is it mandatory to be awake for the first part of the surgery?
So one viewer says, is it mandatory to be awake for the first part of the surgery? The answer is it's not 100% required, but it's advised. And the reason is I need to know if I've hit the nerve root with my needle. And the only way to really know for sure is for the patient to tell me. And of course we did not hit the nerve root, but God forbid had I hit the nerve root, I would need to know that right away before I go any further. Otherwise I could cause permanent irreversible damage to the nerve. So is it mandatory? The answer is no, it's not mandatory. It's recommended, but I could still do the surgery very safely without it. But it's more risky, and I don't like taking any risk that I don't need to take with someone else's health. Standby laser. Look at that herniation right there. Take this. So to answer your question, we can do this surgery without the patient being awake in the beginning, but it's not advised, but it still can be done safely. Anybody know who this is? Huh? John Bon Jovi, that's right. You an 80s rocker? Nice. Me too. Me too. You show me what? So Spotify is music, right? Laser on, please. All right. How popular is Spotify? Is it for a different platform like the Android, or is it also on the iPhone? What's the difference between Spotify and Pandora? Except Pandora streams data, right? Does Spotify stream data? Huh? You don't know? It's a subscription service? Do you have it?
I have it.
And you like it better than Pandora or what?
Well, I think they're pretty much similar. Obviously, when you're paying for the service, you control, what you can search and advance the songs and make the playlist. So
Right.
I'm sure Pandora, you have that option too.
Yeah, I do. I can thumbs up my song on Pandora, and if I have a channel, like a radio channel, I can thumbs up the certain songs that I like or thumb down them, and they get rid of the thumb down ones.
Yeah, for some people, the people who are really addicted to sound systems, some of the files and other services for quality of sound is something that's superior, but
So Spotify has a better sound, more digital information.
I'm not sure about Spotify, but there's other services that they do. That they,
I see.
people who are really fan of, quality sound.
Yeah.
But for when we use it, I don't think it's a significant difference.
So you're saying that my hearing is impaired?
No, it's not that. So we're gonna be content with any music right now.
I wouldn't be content with Luis singing opera. Sorry, Luis. Did I answer the last question adequately, Zach?
Yes, sir.
All right, good. Fact of the matter is that we like to have fun sometimes here at Deuk Spine Institute, but only between 2:15 and 3:45 every afternoon. Right. All right, there's a piece of herniation right there, stuck down. This is the annular tear we talked about if you were here earlier, and there's a piece of herniation. So let me see if I can grab it. Standby laser. It's pretty big. If I can't, it's okay. It's not the end of the world. We just take it out in little pieces. Looks like we're going to be taking it out in some more smaller pieces. Doesn't matter how you get it done as long as you get it done. You can see the pink right there, granulation tissue. It's part of the source of the back pain. All right, so for those of you who haven't watched this surgery before, you're watching an endoscopic spine surgery. And this is a special type of endoscopic spine surgery, different than the more usual types in that this is only a 7 millimeter wide tube. And to be able to do this surgery, it takes a very special skill set that's not found in 99% of spine surgeons. They don't know how to do this type of surgery. They know how to do a larger tube, and they know how to take bone out to get to the disc herniation. We're getting to the disc herniation without removing any bone. And that's one of the things that makes this standby laser procedure so unique, is leaving the normal spine bone there so that you don't get problems later on. Of course, it floats out after I take the laser out. All right. So right now I'm using the laser fiber to clean up the annular tear, which is responsible for all the inflammation that causes the back pain and the leg symptoms. Now the herniation can also pinch the nerve, and I'm removing that as well just now. So I'm removing the herniation, and I'm also debriding the annular tear. Most of the Deuk laser disc repair is an annular debridement. About 90% of it is annular debridement. So that's what separates it from a discectomy, a typical decompressive discectomy, is we're doing a discectomy, but not for decompression. We're doing a discectomy to remove the pain coming from the disc. We call that discogenic pain, as well as the radiculitis, or inflammation of the nerve root from the annular tear inflammation. Great song. Turn it up a little bit, please. Since there's no questions, we're going to crank up some rock and roll. A lot of this is scar tissue, by the way, for those of you wondering. Some of my expert viewers know this is scar tissue, but for those of you who haven't seen it before, scar tissue is white and it's avascular, meaning it doesn't have really any blood supply. Granulation tissue, on the other hand, is young scar tissue, full of nerves and blood vessels, and it's pink. Remember, all this surgery is done through a tiny half of the width of a dime incision on the patient's back. So this patient's going to be going home in an hour after the surgery is over. The surgery will be done in about 20 minutes, maybe 30 if we add the rhizotomy. And they're going to go home probably at, what time is it now? 1:30? Say 3 o'clock today. In about an hour and a half, they'll be going home. I expect their back pain they came in with gone. Their leg pain they came in with gone. Now he has some hip pain, which we're not fixing with this surgery. So I would not expect the hip pain to be gone. That's going to be treated at a later date. But we've already talked about that. And you may get to see this patient a second time because they're planning on doing the neck herniated discs in the neck next week. So like many of our patients, this patient is flown in from out of state for this surgery because nobody performs this surgery where they live. And they live in the Northeast. Very famous city, yeah. How did I come up with these laser settings? Well, one day I took these dice. I'm kidding. I just practiced with different settings and found that these were the best settings. I also talked to surgeons like Dr. Young to see what he does, Anthony Young, and these are really good settings. Dr. Young mostly uses radio frequency. He doesn't use laser. I use laser. I just kind of trial and error came up with the best settings. They've worked really well for me. It's like everything else in life. You kind of find the right, the right setting for what you're trying to accomplish. But it's through trial and error process. You take an educated guess at first and then you just modify it after that. So I'm pretty happy. This is going very well. I'm looking lateral right now, so I'm dealing with lateral herniation. Can you guys hear me okay, Zach?
We can hear you.
All right, so we're just about done. I'm going to wrap it up here. At 12 o'clock is the traversing nerve root, and at 9 o'clock is the exiting nerve root. And I could show you that today with this surgery. All that fogginess of the water in front of you right now is due to pieces of fragments of herniation coming into the water and obscuring the water column. Be done in 1 minute. There's the end plate, that pink thing at 3 o'clock. That's the end plate of, what level are we at? We're at 3-4. That would be the end plate of L4, the superior end plate of L4. Just to give you an idea of where we are. Of course, there's a little bit of epidural vein bleeding, no big deal. It's minuscule. And I've worked with the blood obscuring my field of view for many years, so it doesn't bother me.
We have a question.
We have a question, absolutely. I'd be happy to answer it.
We have a viewer asking, can this surgery be used to remove a spinal tumor?
So somebody says, can this surgery be used to remove a spinal tumor? The answer is generally not. This is a surgery for herniated discs and spinal stenosis. But that being said, I can remove your spinal tumor very, very well, most likely, but it depends on the type of spinal tumor. So if you have a very complex spinal tumor, then I would want you to go to a university hospital. If you have a simple spinal tumor to remove, that's something that we can do at Deuk Spine Institute for you. And we may be able to use the laser to do it, but generally the surgery you're watching is for repairing herniated discs, bulging discs, that type of thing. All right, we are pretty much done. I'm ready for our medicine. I've gotten rid of the herniation, folks. And now we have a cavity of where the herniation used to be. I'm actually going to just do a little bit more up here in the corner. I can't rotate for some reason. Good.
Better?
Yeah, right there. Hold it for me.
Yes, sir.
Nice. Good teamwork. Yeah. I like it. All right, let me see what I got. Beautiful. So surgery is a little bit like fly fishing. In fly fishing, you gotta cast out and jiggle the lure around a little bit in the current to catch your fish. Here I'm kind of casting out the laser and jiggling it around a little bit with my finger in the water to get the herniation. Who's on the phone? Oh, okay. Can you answer it? Or is it too late? Are they on the phone? I wouldn't call them back right now. Just leave it.
So the first patient,
Uh-huh. Yeah.
she's still having less leg pain, but she said she wants to go home
Well, just...
tomorrow.
Yeah, I want to see her first before she leaves.
That's kind of what I told her.
Yeah, tell her we're not ready to discharge yet.
Okay.
I need to come out there and see her. All right, laser off. So let's go up here. You can see the nerve root is right there. So we were just underneath it. And let me have the laser.
Later?
Uh-huh. All right, let's see here. So I'm just gonna go lateral. I need the laser on, man. You gotta try to stay with me. When you see the laser go back in, you just gotta turn it on. I don't wanna have to stop what I'm doing. So I'm just getting rid of this lateral herniation. I'm pretty happy with that. Standby laser. Okay, we are done with this level. Standby scope. Okay. Light on. We need a light on here. Thank you. Relax. Let me have it. Okay, we finished one level. Now we're ready to get to the next one. So the next step is take this. Come on, you shouldn't be doing that with one hand. Make sure you get the stylet out before you do anything else, Luis. Don't make bad choices. I need the fluoro in. You should be moving in, Jordan, already. Hold this here. Don't touch that. Leave that alone. Focus here. Okay? This is where I need your help. It's the same thing every single time. Okay, I don't need you on an AP. I need you on a lateral at this point, since we already have the needles in. Yep. Let's get a shot. That's where we are.
Ben, you can shut off this
All right, so I'm going to take the needle out and leave the guide wire shot. Good. So you can see the needle tip is at the foramen. Good. We're going back through the same incision we did the first surgery on the first disc shot just a few minutes ago. So we're already down at the foramen. Let's go to an oblique. Drop my side a little bit, please.
We have a
There
question.
you go. That's good, right there. Yeah. Shot.
We have a viewer asking, after you have completed the surgery, what is the
Take-
chance the patient has a relapse of their previous symptoms at the same levels?
The chance they have a relapse, so that after I complete the surgery, what's the chance the patient will have a relapse of the previous symptoms? It's about 1%. And that's only, go back to a lateral, that's only if they re-injure the disc. So they'd have to do something they're not supposed to do to re-injure the disc. So not following my instructions of lifting restriction, bending restrictions, that would cause the disc to re-injure. Shot. Take. So the chance of it happening with a recurrence of their symptoms from the same level is 0 if they follow their instructions. Shot.
Ben. Ben.
But if they re-injure the disc by doing something they're not supposed to do, which happens 1% of my patients, by the way, 1%. So we've had about almost 1,000 of these laser surgeries that I've done in 13 years, and we've had 9 patients with recurrent herniations. I'm looking for you for a shot. Is that it? Is that it?
Yes, sir.
Shot? So about 1% of the patients will have a recurrent herniation. That's it. Shot. Good. Shot. Good. All right, let's get the fluoro out. So this is actually a permanent fix for patients that have a herniated disc. We've looked at 6 years average follow-up with a minimum of 5 years of follow-up after surgery. The average for the group was 6 years, and it was 95% relief of their preoperative back pain and 95% relief of their preoperative leg pain. So at 6 years after surgery, we had about 65 patients, and the average was 95% relief of back and leg pain they had before the surgery. Now remember, your back has other discs, so you may end up getting an injury somewhere else and having back pain, but it won't be the same area as you had before. Laser? That's like saying, yeah, somebody broke my window in my house, I got it fixed, and then you have a different window break, and you can't get upset with the window guy who fixed your window because he fixed the one that broke before, but now you have a different window broken. What a lot of people don't understand about backs and necks, lasers on, is that you have about, so let's count it. L1, 2, L2, 3, L3, 4, L4, 5, L5, S1 on the right and left, that's 10. Then you got your discs, L1, 2, 2, 3, 3, 4, 4, 5, 5, 1. That's 15. Plus you got your vertebral bodies that can fracture, right? So that's another 5. That's 20. Then you've got your sacrum that can fracture. That's 21. Then you got a coccydynia where your coccygeal ligament is injured. That's 22. And then you've got infections. So let's just call that 23. You have your sacroiliac joint left and right, 24, 25. You got your two piriformis muscles, 26, 27. And you got your paraspinous muscles left and right, 28, 29. You've basically got 29, and that only includes spine things, 29 causes of back pain. Each one of them can cause horrible back pain. And then that doesn't include like kidney stones, aortic dissections, pelvic problems like uterine fibroids or, ovarian cysts, which can also refer to the back. So there's literally probably 40 or 50 different causes of back pain. And what I fix with this, it's dripping all over my foot. What I'm fixing with this laser surgery is the disc, a herniated disc. That's only one cause. So each disc is 1 out of 30 or 40 causes. So 1 out of 40 causes I'm fixing. I'm fixing 2 out of 40 causes of back pain. But these 2 right now are the cause of this patient's pain. So is Dr. Patel ready? We're also going to treat this patient's facets because I think he has a component of facet pain. So we're going to do a combination of disc repair plus facet rhizotomy. Let's get the white light down just 1 click or 2. It's a little bit overexposed. Yeah, that's perfect. I'd go up 1. There we go. So this is the annular tear. This is where his pain is coming from, at this disc. You can see some pink granulation tissue, not much, but a little bit in there. So I'm fixing 2 out of, let's just say, 50 total causes of back pain. So when people develop back pain in the future, it won't be from these discs that I fix. It'll be from something else if they get it, unless they misbehave during the healing period, which takes, oh, look at that herniation right there, which takes a full year to heal. Okay, it takes a full year to heal from this surgery for the disc, to completely heal. So if they re-injure their disc prematurely, there's another herniation. We call that, yeah, it's a herniation, basically. That's the nucleus pulposus. It has a blue color. The annulus is white. Scar tissue is white. So what you're seeing here is a combination of herniated disc and annulus tear, torn annulus, and scar tissue. Very good questions. So if you have a microdiscectomy, the chance that you're going to end up having problems at that level is about 50% or higher. Okay? If you have a laminectomy, you're probably at about 50% or higher that, within 5 to 10 years, you're going to end up needing a second surgery. More herniation. Okay, and so the Deuk laser disc repair, the chance is 1% that you're going to need another surgery where we had the original surgery done. We call that the index level. So your chances of having good long-term results with back surgery are much higher with Deuk laser disc repair than they are with more traditional surgery, like fusions or laminectomies or microdiscectomies.
We have a question.
Sure.
We have a viewer who says, I have a T11, T12 disc herniation. Would this surgery be an option?
All right. I heard a T11, T12 disc herniation. I think you said something after that, but I couldn't quite hear it.
They're asking, would this surgery be an option?
All right, great question. Wow. So normally I would tell everyone that you cannot have this surgery with a thoracic disc herniation, which is what you have. But your thoracic disc herniation is so close to the bottom that it's close enough to the lumbar spine, we may be able to do it. So I would say 50-50 chance I could do it with this surgery. Not 100%, but 50-50. If you want to know whether we can do it with the laser, I need you to send in some x-rays, MRIs, and I'd love to do a video conference with you. We don't charge for any of those. It's all free. So free consultation. And that's true for everybody, by the way. If you have any problem with your spine and you need our help, we're there for you. We don't charge for a consultation. Just contact our office, talk to Lauren or her team, and you can arrange a 15-minute video conference with me. I do these every single week. Happy to do it. I don't get paid a dime for it, but I want to help people figure out how to solve their problem with their back. There's the tear, guys and gals, right there. You can see it right there. That's the tear in the disc that caused the herniation, and I have to clean it up so it'll heal. What's keeping it from healing is this blue stuff in here. Don't feel bad about having a video conference with me and taking my time. I honestly have nothing else to do, nothing better. I shouldn't say nothing else, I mean nothing better. I enjoy trying to help people, and if my advice, my insight, my experience can be of service to you, then I'm happy to do it, whether or not you come here or you go somewhere else. It's okay. I think it's a really bad idea to go somewhere else, but it's your choice. And nope, you know, adults have to make decisions for themselves. So we do everything we can to help you, prepare you, give you the information, the tools to make the right decision, but ultimately people will choose whatever they choose for their own reasons. I've given up a long time ago trying to convince people of anything other than just the facts. And even given the facts, sometimes people make surprising choices. Right, yeah. Right? So, have you ever had a situation where there's a hurricane coming and everyone's been told to evacuate, but there are people who stay behind? And you might be one of those people who stay behind, and you've got your reason for it, right? Maybe you can't take your animal with you and you want to stay with them, okay? And other people can't understand that, but I get it. So I don't judge people based on their choices they make. I don't have enough information to really make a determination whether or not somebody's decision is the best decision for them or not. That's their choice. So I don't have a problem trying to help people. Whether they take my advice or not is up to them, but at least I've done everything I can to help them. So I've done my job as a good doctor, and that's what I want to do. Make sure I do my job right. So I'm just finishing up this herniation here. It's there's a lot of scar tissue actually superficially towards the surface of the disc herniation where I'm working right now, and so it's gotten a little tougher to remove stuff. And that's typical, though. It's nothing unusual, nothing I didn't expect. So this is kind of par for the course for this injury. If those of you who are watching carefully, you can see how effective the laser is at removing herniated tissue and cleaning up the annular tear. There's a bone spur right there. Yeah. So those are the fibers of the posterior ligament right there, and just underneath it are the herniation. It's kind of neat when you really understand the anatomy on an endoscopic level. How are we doing on irrigation, folks? I'm starting to get bubbles. Are we okay? All right. I need about 30 seconds more and I'm done. Can you do it? Can you do it? Is it safe? Do you want me to have him come? Would it be better to have him come for a few minutes? No, it's up to you. You tell me.
He's stable, breathing on his own. Honestly, I have no problem doing it.
Okay, I'm fine with that. As long as it's safe. That's the most important thing. Standby laser. All right, let's go look. There's the nerve root again right there, that white thing at, I'd say 9 o'clock. You see that white membrane? And then above it is fat and veins. So that white thing is the nerve. We've gotten all the herniation off of the nerve. And I could probably get just a little bit more of that annulus. It looks lumpy. Wait. Done in 30 seconds. Who is it? Can answer it. What does he need? Done. Laser off. You can tell him I'm done. What is it? All right, if you have any questions, folks, I'm going to go answer them in the conference room. Scope off. But we're done with the 2-level. And this is a 2-level Deuk laser disc repair. We're going to do our rhizotomy next because we're including that with this procedure. This patient has some facet pain. But honestly, I think most of his pain was discogenic. So,
Whatever you guys want to do. I didn't see him before.
yeah.
I have no problem doing it.
I would say let's do it because that's what we plan to do. But he clearly had 30 and 40 out of 10 pain at the disc. But I think given the fact he's traveled so far and it's reasonable to do, and clinically he did have facet syndrome, I think it's reasonable to do it. All right, I'm going to come answer questions in about 5 minutes, maybe 10. I have to go see our first patient and say goodbye to her. So go ahead and type your questions. Yeah.
He said when you get a chance, he needs your passport.
For Apple?
He acted like he was
Yeah. Okay, Dr. Deuk here. I am back. I just visited our first patient, and she is recovering nicely. She is complaining of some discomfort in her left leg, and that is because basically normally when we do the Deuk laser disc repair, we add a little bit of medicine to reduce the nerve inflammation at the nerve that we're operating on. We could not use that medicine today because she chose to have stem cells. So basically the use of stem cells, which promote inflammation within the disc, you don't want to use an anti-inflammatory outside the disc where the nerve is, though they're close by, because that medicine could affect the stem cells, and you don't want to do that. So she's doing good though, and she's ready to go home in good spirits. So we are just finishing up our second laser surgery. We're adding a rhizotomy where we deaden the pain nerves to the facet joints in the back of the spine. And I'm happy to answer questions. Zach says we have 3 questions so far from the audience, and I'll take them in order. First one.
Will the parts of the disc that you took out regenerate?
Okay, so somebody said, Dr. Deuk, you took out some disc material. Will those parts regenerate? The answer is no, they do not regenerate. Once that herniation is taken out, it's out, and it never grows back. The disc is a, basically, I don't know exactly what age, but sometime in the development early, usually probably in the first 10 years of life, your disc is finished growing and developing, and it is fixed, it's set. So any type of injuries to the disc after the age of 10 are going to result in a permanent injury that cannot fix itself. Now, the reason people get herniated discs, they get pain, and the pain goes away, is because they actually heal that injury to the disc, but the herniation that comes from that injury never goes away. It's always going to be there. So you can't really get rid of herniations unless they're surgically removed. But you can get rid of the symptoms from the herniation if the disc heals itself, which is what people hope for, and that's what happens the majority of the time. It's only in a small percentage of people with herniations where the herniation doesn't heal properly. They continue to have symptoms of neck pain or back pain, along with arm or leg symptoms like pain, shooting down the arm or leg, numbness in the arm or leg, tingling, pins and needles in the arm or leg, or weakness in the arm or leg. Any of those radicular symptoms, we call them radicular because they have to do with the nerve roots. Any of those radicular symptoms or pain that persists after a herniated disc are really what we're targeting with the Deuk laser disc repair procedure to fix. All right, next question.
My doctor said I needed a fusion. Are there any disadvantages or reasons that I would need a fusion and not the laser surgery?
Okay, we have another viewer who says, my doctor told me I need a fusion. And are there any disadvantages or reasons why I should do a fusion and not laser? The answer is you should always do laser over a fusion. That's why we broadcast, is to educate people about other technology that are better than fusion that are available. So the answer is the only time I would really recommend a fusion over the laser is in the rare chance that your fusion is being recommended for a condition called spondylolisthesis, but it has to be a grade 2 or 3 spondylolisthesis. If you're having severe slippage, and I'm not talking about mild or maybe mild to moderate slippage of bones, but severe slippage, which is a grade 3 really, you definitely want to do a fusion over the laser surgery. But for a grade 1 slippage or maybe even a grade 2 slippage of the bones called spondylolisthesis, you can actually do the laser surgery and have an even better result than a fusion. Other than that, for every other cause of fusion, I would say probably 98% of those fusions could be switched to the laser surgery as a much less invasive, non-implant based, non-metal, non-plastic, based treatment, which is much better than having open fusion or even minimally invasive fusion. Hold on one second. All right, sorry, I had to deal with a question about the laser. But so 98% of the time, if you're recommended for a fusion, whether it's on your neck or your lower back, you should have the Deuk laser disc repair over the fusion because it's so much safer and much better results and a much faster recovery. Okay? Next question. Sorry about that. So the next question is, I've had my disc fused from surgery and still have back pain. Is there a surgery out there that can help? The answer is yes, for sure. So the reason I can say that is because the only time people get pain, even when they have a fusion in their spine, is when they have movement at a muscle or a joint. So the discs that are fused are not causing your pain. Now, your pain could be coming from a variety of things, and there's literally a list that I would have to go down in order to be able to answer your question. But, for example, the most common cause of pain in the back after a fusion would be the disc above or below the fusion. So if you had an L4-5 fusion, then the next disc below would be L5-S1, or the next disc above would be L3-4. It could be that your L3-4, L4-5 are the problem. It could also be the facet joints above or below the fusion. Those are common causes of pain. It can also be your sacroiliac joints, which are next to where you had your fusion, or your piriformis muscle, or your paraspinous muscles. Or it could be an infection or even a tumor, which would be extremely rare. So there are a lot of causes of pain in a patient who's already had fused discs. And you need somebody like me who's very experienced to be able to figure out what's causing your pain. I cannot do that over the phone. I have to do that in person, looking at you, examining you, seeing where your pain is coming from in relation to where you've had surgery. So to answer your question, can we help you if you've had prior fusion? 100% yes. Can I do it over the phone? Nope. Can I do it with just an MRI review? Nope. What do I need? I need to do a physical exam. I need to actually put my eyes and hands on your body here in my office. So plan on making a trip. Send your MRI scan ahead if you'd like. I would also want a CAT scan, x-rays, and depending on whether there's some weakness or numbness, we may need a nerve test as well. But have faith and hope, because we can definitely help you. I just can't tell you exactly what needs to be done over the phone without making a specific diagnosis. All right, anything else, Zach?
One more.
One more question.
Does anything fill in the empty canal that you left in the disc?
So the question is, Dr. Deuk, you did a great job of removing that herniation. There's a big pit there now. Does anything fill in that empty hole where you took the disc herniation out and you showed us? The answer is yes. In time, what will fill in that empty hole is that's where the disc will heal to seal off that hole. So the left side and the right side, or the top and bottom, however you want to look at it, will send connective tissue across, and they will join in the middle, and they will seal it off with your own body's healing process. That's exactly the process that was trying to heal the herniation in the first place, but it wasn't working because the herniation was still there. So I went in and zapped that away, and by removing that material, I'm able to let the annulus fibers close together. All right. So great having you all. Thank you for watching today. And we may be back in 30 minutes or so with our patient. If he wants to be broadcast his recovery, then we'll broadcast his recovery if he allows us. Okay, other than that, thanks for watching, and we have more surgeries on Thursday. So tune back in. By Thursday, we're going to have our app launched as well, right, Zach?
Yes.
Zach says with a very confident tone in his voice, yes. So we plan to have the Deuk Spine Institute app. We went through it today, and we made all the final changes with Zach, what we want. Zach has to implement those changes into the programming of the app, and then we're going to have it launched Thursday. So maybe we'll launch it Thursday along with the beginning of the stream. What do you say, Zach?
Yeah, sounds good.
Sounds good, he says. All right. Thanks for watching and participating. I'm Dr. Ara Dugmajan, joined with Zach here, and we're broadcasting live from Deuk Spine Institute.